All right, who's been on that call for a headache? Right, you called out 911, 2 o'clock in the morning for a headache. Right, it happens. There's nothing you're going to do to change that perception. But consider they probably wouldn't call if it wasn't an emergency to them. Now I'm trying not to include our drug-seeking population that may be calling because they want to get some sort of pain medication. But headaches can be very painful. There's 4 general types of headaches. And it's important that you guys understand what these headache types are. So the most common one that we're probably going to see is our migraine headaches. Does anybody get migraines? Yeah, you taking a medication for it?
I used to.
Yeah.
They suck.
You used to get pretty bad?
Yeah.
Yeah. So patients with migraine headaches, real quick, because this is reminding me, they're going to have an aura, right? What's an aura?
It's the feeling that they're going to have a seizure.
Okay. So that was something that I wanted to mention with seizures too. With our grand mal, petit mal seizures, a lot of times patients who've had a history of seizures will experience what they call an aura. It's either a taste, generally it's a taste, like a metal taste in their mouth before they start to seize, or they might hear something, or they might smell something. So when I pick up a patient who's had a history of seizures, I ask them, do you usually have an aura before your seizure? I'm like, yeah. Well, what is it? They would tell me what it is. Now I'm paying attention to that, and I say, well, let me know if you sense that. And I've had that happen. We're like, hey, I'm starting to taste that metal. Sure enough, within about 10 seconds, they have a seizure. That aura is the same with migraines. A lot of patients that suffer from migraines will also have some sort of an aura. A lot of times it might be halos around things. They might hear things, but that lets them know that, hey, this headache's coming on, and they can take a medication for it. But what causes a migraine?
It's a narrowing of the vessels and the...
They talk about it as like a narrowing, and I think that's how the book puts it, but it's basically a change in the size of blood vessels. And ultimately, it's almost like a rapid dilation and constriction of those blood vessels in the brain. And what really causes it, they don't know. But a lot of patients that have migraines will find a heavy caffeinated drink when they kind of get that if they don't have their medication. So the big one that I used to hear the patients would take is Mountain Dew. They would guzzle a bottle of Mountain Dew if they knew a headache was coming on. But it's basically a rapid change in cerebral blood vessel diameter.
For the brain freezes, right?
I've never actually studied what causes brain freeze.
I remember reading that you drink something cold and the cerebral artery kind of spans out.
Oh, yeah. Patients will describe this as a throbbing or a pounding,
Yeah, I just wrote that.
sometimes pulsating. So the one thing is light. You're light sensitive. Pretty much any of the senses. So lights, sounds, they're very sensitive too. So when you transfer these patients, give them maybe like a wet cloth, put it over their eyes, turn the lights down on the ambulance, and that's probably going to be the best way to transport them. They also are very nauseous, so you're going to see nausea vomiting with them, which means you're going to want to get IV access. You want to have some Zofran probably ready for these. The other set that you're going to see is tension headaches. And these are basically just stress-induced. A lot of times it's the muscles of the neck, the face, and the upper back that just are constantly kind of contracted because of whatever stressful environment they're in, work, school, whatever. And these patients end up getting these tension headaches. These kinds of headaches are easily resolved with like either a muscle relaxant or some sort of an NSAID to kind of help with that. A lot of times they just need to relax, de-stress, and those headaches go away, but we'll get calls for those all the time. Typically they're described as more of a dull ache. And the ache that they have is going to be bilateral. which means it'll be on both sides of the head or the back of the head. It'll be equal on both sides. Cluster headaches. Cluster headaches are headaches that come one after another about every 30 to 45 minutes. So they'll end up with multiple headaches about every 30 to 45 minutes. The pain that they experience is unilateral. They're thought that this is caused by serotonin or histamine. Now don't go and give them Benadryl. Here's the kicker with this. These types of headaches can last from days to months. So very debilitating. They cause a lot of pain, and they're one after another about every 45 minutes for months. The last one is sinus.
Any treatment for those cluster?
What's that?
Is there any treatment for the cluster headaches?
Pretty much the same as anything else. Just try to keep them calm. The cluster headaches themselves are going to be prescribed probably some heavy painkillers to try to knock that down. This is something where they're working with probably pain management because they get these all the time. This isn't something that just comes out of nowhere. Cluster headaches, typically these patients just survive their life with it. Sinus headaches, these are going to be your infections. So you're going to have some sort of a sinus infection. We've all kind of had that where you get a lot of mucus and a lot of buildup. These patients are going to have postnasal drip. So if you actually take a pen light or your flashlight and look at the back of their throat, you're going to see banding of mucus that's coming down from the nasal cavity and dripping down into their throat. That's called postnasal drip. That's also going to cause a sore throat. Because whatever germs are dripping down the back of their throat is also contaminating their throat as well. So they're going to have a sore throat. And, well, they're going to have a runny nose. If I wanted to differentiate between all these headaches, what is one thing I can have the patient do that's a positive test for a sinus headache?
Blow their nose.
Okay. Have them lean forward. Right? They've got a lot of pressure and a lot of fluid in their sinuses. Leaning forward will increase that pressure and it's going to hurt. So have them just, and you don't have to have them bend all the way over, just have them lean forward a little bit. So leaning forward makes the pain worse. So why do you guys need to kind of understand the different types of headaches? Right? Hemorrhagic stroke, the #1 cause is a headache. So next time you get that headache call at 3 o'clock in the morning, you can be irritated, but realize that, it's always, you have to rule out the fact that they're having a stroke. So then you can kind of go through a little bit of a differential diagnosis by how these patients are presenting, where they're complaining about pain. This pain is in the face and forehead. So the biggest thing is you want to do. Now, as far as treatment that we're going to do in the field, some counties will allow you to do Toradol, but a lot of times that's what they give in the hospital. It's called like Supermotrin. It is an NSAID. It's an injection. If you guys find an area where you can give Toradol, they're talking about 30 milligrams as an average dose, IV or IM. A lot of times we're giving this just IM. Morphine, you're going to give like a 2 to 4 milligram dose. And I don't know of anybody that's using Demerol, but they'll do that in the hospital. If I were to give fentanyl, what would I give? How much?
50, 25 to 50.
I'd probably go more 25 to 50 for a headache. Now, some counties may not let you do pain management per headache, at least standing order. So if you really believe that it was one of these kinds of headaches, and really all they need is pain management, call and get a base order, explain your vital signs, give them paint a good picture, and you might actually get an order for it, because it's going to make them less likely to stay in the ER and turn that bed over faster if they can. They'll still do a CT on it just to make sure, but it'll kind of get them out. The other thing with headaches, oftentimes they present with nausea, vomiting, so be prepared for Zofran or Phenergan. As far as everything else in the neurological emergencies, you guys, make sure that you go through that and look at multiple sclerosis and dementia and those kinds of things we talked a little bit about. But I'm going to leave that to you guys to make sure that you get that covered. If you have any questions on that, please feel free to send me an email or ask me a question after class. Other than that, I'm done. Guys, come back at 1:30. Enjoy your lunch. Sure. And that is my lunch. What you got?
The unilateral pain and the bilateral pain, like on one side of the head.
Yeah, so if it's unilateral, it's usually just one behind an eyeball or something like that.